Good morning, everyone. Thanks very much for being here. We're going to do a quick introduction, and let's see, we should have the share going up now.
So while you're doing that, Patrick, I'll just remind people where the hands up button is at the bottom. Okay, that's at the bottom, and you know, to reactions, if you go over to reactions and you click on that, you can see the raised hand.
Okay. Yeah, and that's going to work a lot better for us because trying to watch the chat function with people who want to ask questions and interact, people can get lost in the chat there. So if you can raise your hand, that bumps you up on the screen. So we thank you for that. Natalie already went through the on how to do that. Is there anyone who isn't clear on how to raise and lower their hands? If you could indicate in the chat. Oh yeah, if you're not clear on how to raise your hand, please raise your hand. No. So we are in the Why Not Privatize 101 Public Healthcare and Privatization workshop this morning. And again, if you wanted to go into taxes and public services or building the movement for public health care, please go ahead and text or put into the chat to Sala your choice. To go over this morning's agenda very quickly, first we're going to have an icebreaker. I'm sure that at some point we'll get back on the schedule very quickly and not interrupt too much for lunch. We're going to brainstorm what is public health care. We'll have a discussion after that. And again, to brainstorm what is privatization. Then we'll welcome Hugh Armstrong, have a brief exercise after the question and answers from Hugh. We'll break for lunch. And since you're in the main room, we don't have to worry about not exiting Zoom and getting back in, so that'll be fine. Once we get back from lunch, and we will start right back at 12:45 so that we can get back on time for our afternoon speakers. We'll go over some resources that we have available with the OHC. We'll have another guest speaker, Paulette from Oxfam, and a discussion on the who benefits from healthcare privatization. That'll be followed by a briefing from Natalie on what our current government, what their fiscal plan has in store for us. So hopefully people don't have a soft lunch, work through the afternoon, and then we'll brainstorm of how we get all of this information out to our communities, and then we'll return back to the main room. So let's start off with a quick introductions, and to do so, we've kind of worked in an icebreaker here. So in your introduction, if you could say, oh, I'm sorry.
Yes.
Yes, Anne. And you're on mute, Anne.
Yes, you were calling me about something, Patrick. Can you hear?
I'm sorry.
Is it Anne Kajerski-Colley or there's another Anne?
I think that I may not have enunciated properly. I wasn't calling on you. Thank you.
Okay, great. Thank you.
Yeah.
Okay.
No worries. No worries. So we'll start off with introductions and icebreaker.
Mm-hmm.
So if you could take a look at the list that's on your screen now,
Mm-hmm.
the column on the left and the column on the right. How would you describe yourself? What noun would you use to describe yourself? And then one word from a column on the right, what verb would you use to describe yourself? And if everyone wants to, this would probably be a good time to test out your raise hand and lower hand, because what that'll do is that'll help us put everybody in order of when they raise their hand. So everybody to get in on this pressure, please raise your hand.
Okay, maybe I'll start, Patrick, for myself so people can understand. So I am an advocate, and my first name is Linda. I'm an advocate, and I'm very messy.
Fantastic. Thank you. And
Patrick, you are?
And I've been in a number of these things. Right now I am an advocate, and I would say that I am definitely not calm.
Okay. How about Karen?
Karen Henderson, good morning.
Good morning. I'm Karen Henderson. I'm the founder of the Long-Term Care Planning Network. And on the left, I am an other, because I'm one of the very few people in this country actually educating Canadians about what long-term care really is, how the continuum works, what governments do and do not pay for, all the stuff they need to understand and they don't. And on the right-hand side, I would say that I'm fierce.
Fantastic. Thank you very much, Karen. And next we have Rachel Mehra.
Hi, I'm actually many things on the first column there. I'm a healthcare worker, a caregiver, a union representative for ONA, as a bargaining unit president, and I'm fierce and angry.
Fantastic. Thank you very much, Rachel. And next we have Bonnie. And Bonnie,
There we go.
There we go.
Yep. So I guess I would say I'm an advocate and a concerned citizen. You were supposed to do one though, right?
Yes, only one.
Well,
Yes, one is good because we
Okay,
have a
it's
lot
too
of
long.
people in here. So
Sure.
yes.
So
First name, pick one on each side.
Bonnie, and I'm an advocate. I guess I would say I'm fierce, not in a nasty way, but in a passionate way. I live in Haliburton County, and our group came to be Haliburton City of Port Lakes, which is Lindsay area, Long-Term Care Coalition, a year and 3/4 ago. So we've been doing a lot of advocacy around the long-term care issue in our community, and we have had no outbreaks. We are so lucky with 3.
wonderful.
And all our residents are out in the common room. None of them are isolated. So we're so fortunate.
Fantastic. Thank you so much, Bonnie. And next we have Pat and Armstrong.
Hi, I'm Hugh Armstrong, and my computer doesn't work very well, and so it says Pat and it doesn't say Hugh. I suppose I'm an academic and researcher, retired prof, but of course I'm also an advocate and a concerned citizen, so it's hard to categorize me. Bookish and nerdy, but also definitely not calm, definitely fierce, often messy. So that's me.
Wonderful. Thank you. And we look forward to what you have to say for us this morning. Next, we have Shirley Sherman. Sherman?
Okay, concerned citizen and messy. Long time
Wonderful.
long-time OHC.
Wonderful. Thank you very much. And next we have Christine Collins. And Christine, you're on mute. There we go.
Hi, I'm a member of the Ottawa Health Coalition. I'm an essential caregiver, and I'm definitely not calm.
Wonderful. We need that passion. Thank you very much. Next, we have Ann Clark. And Ann, you're on mute. There we go.
Ottawa Health Coalition. I'm a retired nurse, I've been involved in unions for about 34 years, very passionate, and I am definitely fierce.
Perfect, perfect. Thank you very much. Next we have Paul Kennard.
Yes, it's Paul Connor. I ran the Ontario Electricity Coalition for 10 years. We stopped the sale of Hydro One in a province-wide campaign and court case in 2002, and then the Liberals came along and sold it. So I'm more than a little interested in this subject, and you know, that's for sure. And I would describe myself as fierce.
Perfect. Thank you very much, Paul. Next we have Dorothy Klein.
Yes, I'm Dot Klein, and I'm in Sudbury, and I'm with the Sudbury chapter. I'm one of the co-chairs of the Sudbury chapter of the Ontario Health Coalition. I consider myself an advocate, but I also consider myself a concerned citizen and healthcare worker, because I've been a registered nurse and still am since 1965. So that's 57 years. And I'm a caregiver as well with a disabled son. I consider myself, which is a word that's not there, as persistent because I've been advocating in healthcare for 57 years. Thanks.
Oh my, that's fantastic. The years of experience there.
But Patrick, I just have to tell everybody, right? If you can stick to one from the left and one from the right, because we have 68 people in the room and we won't get through this. I'd love to hear, as we go through, maybe we'll hear more about each other. Okay, so we're just trying to get everybody to briefly introduce themselves by name. Pick one from the left, the first column, the one noun, and one adjective from the second. Thank you. Okay, Elaine.
Advocate, not calm.
Thank you. Christine.
Christine Collins.
You already did me.
Oh, sorry. Well, how about Malcolm Buchanan?
Yeah, union rep, Congress of Union Retirees of Canada, and definitely not calm.
Great. Ross Sutherland.
Today I'm feeling like a fierce, loud advocate. Everything many would apply.
Yes. Okay. I lost my list. Can you still follow?
Dawn Leroux.
Yes.
Good morning, everyone. My name is Dawn, and I am a union rep, and I am definitely loud.
Perfect. Nikara Smith.
Good morning, everyone. My name is Nahara. I am brand new to all of this, and I am hungry to learn more.
Fantastic. Thank you very much for joining us. And next we have Marilyn Reagan. And Marilyn, you're on mute. Okay, and next we have MG Kingston Healthcare or Health Coalition.
Hi.
Good morning.
I'm Marilyn Birmingham is my name. My husband and I are running back and forth between two different computers and two different workshops. So my name is Marilyn. I will be listening quite a bit, but I'm not sure how much I'm going to be able to speak. Anyway, I'm a concerned citizen and definitely not calm.
Perfect. And your level of participation, we hope that everyone can, and certainly welcome those who wish to do so. Would anyone else like to jump in on the introductions before we move along?
Stewart.
Yes.
I thought I had.
I'm sorry, go ahead. Oh, we have my screen refreshed here. So we
Go
have
ahead,
Olivia.
Anne, please go ahead. Anne, go ahead.
Hi, I'm Anne from Guelph, and I'm deaf. Can you hear me?
Yes.
Okay, I'm Anne from Guelph. I'm hopelessly messy and a concerned citizen.
Okay, how about
Fantastic.
Louise Derry?
I'm a concerned citizen and I'm nerdy.
Welcome.
Thank you.
I don't know. I have S. Appleton.
Hello, I am a retired person, a concerned citizen, and definitely not calm, having tried to seek out long-term care.
Yes, good stuff. Okay, next I have Ann Beer.
Hi, I am a concerned citizen, retired, not calm.
Okay, great. I've got a repeat again. So, Carol, did we have Carol yet?
Yeah.
Carol Wodak.
Carol Wodak from Alberta, advocate, retired. I wish.
And we do have people who have their hands
very
raised. So we'll go back to the list with people who have their hands raised. Next we have Olivia Chow.
Oh, hi. I'm the executive director of the Institute for Change Leaders and a fierce advocate for a long time.
Well, welcome, Olivia, and it is great to see you here. Thank you very much for all your work. Next, we have Marie.
Hi, Marie, and I am a calm advocate outwardly, but inwardly, I am definitely not calm.
Fantastic. Sounds like you're a government relations person. Next is Susan Balfour.
Hi, I'm Susan, and I'm a concerned citizen, and I am definitely not calm.
Perfect. Thank you very much. Next, we have Anne Gajerski Colley.
Holly,
Wonderful. Welcome.
can you hear me?
Yes. Oh. We
Yes,
did have
I
you on
spoke.
the introduction. Fantastic. So I've just lowered your hand for you. Next, we have Lauren Bruce. And Lauren, you're on mute.
Sorry. I'm Lauren Bruce. I'm president of Waterloo Regional Labor Council, and I've never been accused of being shy.
Fantastic. Thank you very much, Lauren. Next, we have Jeff Hanks.
Hi, I'm Jeff Hanks, co-chair in London, healthcare worker, and we're not gonna take it.
Absolutely, brother. And next up, we have no one else raising their hand on the, Ann Colley, did you wish to speak again? Okay. Nope. All right, so I'll lower your hand there. Next, we have no one on the list. Would anyone else like to, Ann Colley, did you have a question? You're on mute.
I keep trying to turn off the hand and it keeps popping up. So you keep, I don't know what to do about that. So.
Okay, go ahead and lower your hand and we'll move on to Kathy Cottingham.
Okay, hold on. I did have lower my hand and then I right now I'm looking at lower hand and can you hear me? Am I showing up as having my hand raised?
You are showing up now as having your hand raised.
Okay.
What I have been doing and going through the list is that I've been lowering people's hands for them.
Okay.
I apologize for that. That's so that I can see who's next.
Please just lower my hand.
Okay, perfect.
Please, sorry about that. Okay.
No worries at all. So next we have Mary Forbes.
Mary Forbes, advocate union, non-union, and I can be very fierce if pushed far enough.
Oh, perfect. Thank you very much, Mary. Next we have Lance Livingstone.
Hi, I'm co-chair of the Durham Health Coalition, and I'm a concerned citizen, and definitely not calm.
Perfect. Thank you very much, Lance. And next, let's see. All right. So is there anyone else who would like to introduce themselves?
My
Okay.
name is Stewart Ryan. I'm a retired union rep. I strive to be calm, but I'm messy.
Perfect. Welcome, welcome. Kathy Cunningham.
Yes, hi. I am a concerned citizen, and I think you can guess what else I am. And I am fiercely determined, not only on behalf of the long-term care homes, but the senior assisted and retirement homes as well. I'm from Tilbury, Ontario.
Outstanding. Thank you very much, Kathy. And next we have Alan Clark. And yeah, there we go.
So I'm an advocate and I'm messy.
Wonderful. We all, it sounds quite like me. Anybody else like to join in?
Oh, so
Perfect.
Patrick, that sounds pretty good because we're a little bit behind. So I'm wondering if we should move on to the brainstorm. Yes. Okay, so Patrick, I'll just go. So the brainstorm is, what is public health care? Patrick's going to type in the answers. So yes, we're going to have a discussion about what is public health care. And so if you can just shout out, yes, because it's a brainstorm, so everybody can just shout out, what is public health care? What is it to you?
And we're not, you know, in a brainstorm, definitely we don't judge, we don't, you know, we're just trying to get people thinking and on this, moving forward on that. So feel free to just shout out whatever comes up to you.
You can give examples
Essential.
of what public health care is.
Publicly funded.
Yes.
The biggest effect on our health is housing. So I would say affordable housing should be public health care.
That's interesting. What else?
Accessible.
Essential service.
Accessible. Spelling doesn't
Essential
count.
service.
Essential service. Essential services.
Available to everyone.
Being eroded.
Okay. Okay. Poor Patrick.
Comprehensive and integrated.
Available to everyone.
Comprehensive. Yeah.
Publicly delivered.
And yeah, great, thanks.
Portable.
Yes. Publicly delivered. Publicly delivered.
Diverse. Diverse.
Okay, wait, poor Patrick. Yes. Can you get publicly? Yes. Publicly delivered.
Diverse.
Okay.
Equally,
Diverse.
equally in quality,
Equal.
in quality,
Accountable.
Pardon me?
Accountable.
Okay, equality, accountable.
Includes pharmacare, universal single payer pharmacare.
Should include.
Yes.
Emergency.
Should include long-term care.
Yes. Should
Dental
include-
care.
And should include dental care since teeth are part of our bodies.
Public
Yes.
home care.
Pardon me?
Public
Home care.
home care.
Yes, public home care.
All basic human needs.
Should
Is
non-judgmental.
Secure food supply. Livable
Basic-
wage,
Yes,
livable income. Is non-judgmental.
yes.
Mental health care.
Secure food.
Livable. Mental health care. Okay,
Hello,
so
how are
you
you?
have to go so Patrick can type. Watch. Yes. Slow down a bit, please, for Patrick.
And I'm also having a bit of a delay as I type here, so it's
That's okay, Patrick. So what are we missing? People have said stuff. What are we missing?
Non-judgmental.
Non-judgmental. Yes, we missed that.
Food
Mental health
security.
care.
Needs to be accountable and have something like the Canada Health Act enforced to strengthen it.
Food security.
Okay,
Measurable
so
standards.
It
food
should also,
security. And what was after food security?
Measurable standards.
Measurable standards. Okay, so that looks like a pretty good list.
National standards, nationally measured standards.
Yes, national
So that looks like a pretty good list. So because some of this we also need to think about what is public health care, and then also talk what does public health care cover, because sometimes it seems like people may not know, right? So what does public health care cover?
Oh.
Yeah, so you have isn't covered and what's covered. So let's try, what does public health care not cover?
Drugs are not covered.
That's right, drugs are not covered.
Vision
What
care.
else?
Vision care.
Vision care.
and dentistry.
dental.
Dental.
Dental, vision,
Physiotherapy.
physio, yes.
Rehab services,
Pardon me?
rehab services.
Ambulance
Rehab.
rides.
Yeah.
Pardon? Eyes? Ambulance, yes.
Home care services.
Some home care, yes. Did somebody say eyes? Vision?
Yeah.
Yes,
Yes,
sir.
that's not covered for everybody.
Hearing,
Delivery of care.
Hearing aids.
Long-term
Yes.
care isn't covered.
Pardon me?
Long-term care isn't covered.
No, not totally. How does that work? So there may be some people who don't know. Some of it is covered, right?
It's the delivery of care that's not covered.
In
It's based
long-term
on
care,
income.
delete the retirement homes for now, Patrick. So in long-term care, there is, it's a copay, right?
Yeah.
So part of it's paid by the government and the other part, an individual has to pay unless they can't afford it.
Mobility aids.
Mobility aids,
No, some are covered under,
covered.
some are covered under the
Some.
assistive devices program.
Some.
Dentures.
yes. Partially covered, sometimes it's not 100% covered.
Yeah,
Right.
partially covered.
Yes, and
Well,
now
I'm
we
just going
should
to chime in
probably,
here.
go ahead,
I'm just going
Patrick.
to chime in here real quick. Absolutely, like the part of the discussion here of what's covered and what's not covered. When we talk about for an example that I'm familiar with, Trillium, which it partially covers drugs, prescriptions for people who show a need that they can't afford them, but that's a side program that people have to jump through hoops. That have to apply for them and show need. So is that really part of our public health system as being covered, or is, the accessibility by having to apply for these different programs and show need, is that an attack on one of the fundamentals of public healthcare, which is accessibility?
Yeah, I agree.
And some of the things that isn't covered, it like prescriptions, you got to think of that's for anybody under 65. So if you're over 65, most prescriptions aren't covered. So
No.
you gotta.
No, not in Saskatchewan. It's unequal
Well,
between
this is Ontario. We're
provinces.
talking about Ontario.
Well, we can talk about, we can be inclusive here. So I think it's
but
fair.
in Ontario,
No, we're talking Ontario.
Yes.
It's not all covered.
Mental.
In Ontario, it's not all covered for seniors. You have to have the generic, and if you have an underlying reason you can't have the generic, you have to pay the difference for the name brand, and it gets into the filler substances in the
but
generics.
you're losing what I was trying to say. What I'm trying to say is there's a lot of drugs still are covered for anybody over 65. But if you're under 65, you're not covered. So that's why you gotta see, under 65 is not covered. Same with physio. If you have a problem, you can get physio if you're over 65 too. But not under 65. You can get physio if you're under 19. So,
Yeah.
so it all
Also-
depends on your age group here. I
You
know
also
some
have
people
to-
here aren't all from Ontario, but I'm thinking of Ontario because that's what Ontario Health Coalition.
You also have
So
to keep
then
in
this would
mind,
point out something that's not universal,
Yes,
right?
that's right.
Yeah, that'd be better.
Definitely.
you also have to keep in mind that some of these things are partially covered if you're in hospital. So dental is covered if you are in hospital. Some of your medications are covered if you're in hospital. Your rehab, your physio, all those things are covered if you're actually in hospital. It gets gray and weird when you are discharged, because then all of a sudden the medications you were taking while you were an admitted patient are now on your tab. You know, some of the things that you had because you were in for dental surgery or whatever, now all of a sudden it's not covered. And even if you go for dental surgery, some of it is covered, but some of it is not. Even when you go and see a dental surgery. So that's where a lot of the confusion comes in, because you don't know what actually is covered and what isn't. So, you know, things like they'll pull the tooth, but they won't, but you pay for the implant.
Yeah, yeah.
So it gets really gray and fuzzy.
Yeah, but and you're right. And it certainly shows how much public health care we don't have. I just like to add one more thing to the list if it isn't covered, and that is retirement homes, because retirement homes are not the same as long-term care. And sometimes people are confused about that. So retirement homes are totally private and not covered at all. And in fact, some people feel that retirement homes aren't healthcare at all. So I'll just add that to the list. So we'll go to covered, right?
Can I add mental health services?
Yeah. Oh, for sure.
Because I think that's a huge area that if you can afford or have coverage, but mental health is sadly neglected.
No, you are so right. You had said that already, for sure. You know, sometimes we don't even, where I live, we don't even have regular services in mental health at all. You know, it's only from 8 to 5, 9 to 5, no weekends. It's absolutely ridiculous. So you're
And one of the things,
so not only it's not covered, it's not even in existence. Yes, Patrick.
and one of the things that is really, really telling that is coming out is, like, I remember when people would go to the hospital if they had a fracture, get the fracture fixed, get their crutches, get their cast, and be on their way, right?
Yes.
That no longer exists, or it does in some ways. But this is very telling in how our healthcare system has been eroded over time, right?
Yep. No, for sure. No, for sure. It's been completely awarded. So on the list, we've already talked about in the previous question about things that were public health care, and we have our list about what isn't covered. So at this point, it's almost 11:20. Let's think about what is privatization. Now that we have a better understanding of what is public health care, now we're going to think about what is privatization, because we seem to be all on the same page now.
I'll tell you what privatization is. When the conservative, I found this out from someone I know in Alberta. When what's her name? Rona Amber. She was charging, literally overlooking, she's supposed to administer the Canada Health Act, and the Alberta government was charging people for elderly people that couldn't be moved into long-term care, or people who could not be moved into long-term care. Not everybody in there is elderly, but they were charging rent for hospital beds, and this is against the law. She is supposed to administer it, and this was going on in Alberta during the Harper administration.
Yeah, that happens in Ontario. Is that what you're going to say? Is that Lance?
No, I didn't say that, but I
Fee
agree.
for
It is
service.
happens in Ontario if you're in there. Like that was going to happen to my mom.
Yes.
Oh, okay.
Yes.
Because she's going to be there too long.
Yeah.
Yep. So yes. So no, that does happen.
System for the rich.
Yep. So if you're in there too long and it's not even your fault, but you can't get a friggin' room in long-term care, you can end up having to pay and your public health care becomes private. But what is privatization?
I say it's a crime.
For profit, for
Well, it is
profit
a
long-term
crime.
care.
Crime, that's the word.
It's just a person who's not quiet. Yes.
I think it's a lot of contracting out, such as in hospitals, home care services. We have minimal that is paid by the public purse. And so it covers a lot of different fields, lab services. Now all these temp agencies going into long-term care homes to fill in the gaps, and in hospitals. So I think the temp agencies are often, and personally I did work for one when I was in need of money as an RN. So I know they're pervasive. And they're expensive, more expensive than than having your own staff. So I think that is pervasive in a number of areas of our healthcare system. And I think it's growing, and more of it has happened during COVID.
Delisting of services.
Yeah.
For profit.
Listing, yes, that's happening for
Okay.
sure. Go ahead.
And
For profit, long-term care, and P3s.
Public-private partnerships, absolutely.
Yeah.
And for profit, long-term care.
Yes, for profit can cost more.
And
They delisted services by moving x-rays, physio, all the stuff that used to be covered that were done in hospitals, and moved them into private practices owned by physicians.
Yes. Yeah, so moving services out of the hospital.
It's fee for service.
It
Yes.
is fee for service.
User fees, yes, definitely.
It's just carte blanche fee for service. You want it, you pay for it.
And
user fees.
And also it's making profit on the backs of the vulnerable.
Yes.
Yeah.
It's
That's
also
what privatization does, for
That's
sure.
what it is.
It's also anti-democratic. It undermines democracy because the people that get the contracts donate to the government and help them get reelected, so they privatize more.
Yeah. Anti-democratic. Oh, yes.
And it's non-partisan.
I think we have to throw in the word market here. So I'd say market availability.
Yeah.
Market driven
I
instead
hate
of
to say free market, but certainly
market driven instead of being, delivered by need.
Politically driven.
That too.
Partisan, I said earlier, partisan.
Yeah, politically driven. I like that.
How about plain evil?
What's that? Evil?
Evil. Yes, I'd say it's evil.
I'm wondering if it's corruption, and I don't know how to say it, but maybe it's evil to the extreme. But something about conflict of interest, corruption.
Yeah.
Well,
something. I don't know how to say it in a word.
But
that's good.
That's
Accountable.
Yes. Pardon?
That's good, I think.
Yeah,
Not
conflict of
accountable.
interest is very
Deregulation.
And why is it a conflict?
Because the politicians are accepting donations from these big developers that build long-term care homes or build along the highway. What is it? 413 coming through Halton. So and the advisors are often previous campaign workers and tied in with the policies. I don't know if,
Yeah.
oh, that's, I mean, it's evil,
or-
but
Or
it's,
they're ex-premiers.
yeah.
Substandard care.
Yes,
There's a
that too.
corruption.
Many people who sit on the board, or people are more concerned for profit, and it's profit over care.
Yes,
Do you ever think
Or
that
just-
happens?
Ford just
Profit
got
over
caught doing
care?
that.
absolutely.
Privatization is loss of control.
Okay, yes. And when you say loss of control,
Including
so
deregulation.
yes,
It's loss of control and loss of choice.
yes, there's that too, right? Loss of choice.
It is a driver of income inequality because our healthcare system is probably one of the biggest income equalizer that we have to increase, human rights or equality.
Oh, for sure. There's no doubt about that. Driver of inequality.
It's not patient-centered.
Yeah. That's another good one. Not patient-centered.
Well, along with that, someone's point about a poor quality.
Yes.
Poor quality, understaffing.
Yep. It's that too. Understaffing.
Higher
certainly
cost,
living that.
higher death, less satisfaction, and poorer outcomes.
Poor wages.
Poor outcomes.
That's from the Profit is Not the Cure, that paper that came out a while ago.
Mm. Poor
Bad
outcomes?
wages.
Pardon me?
Bad wages.
Yes.
Deliberately breaking the system so they can come in and fix it with privatization.
Okay, I didn't hear all of that because you cut out. What did you say?
Underfunding the system so that they can then come in and privatize it.
Okay, yes. Yes. Sounds like
Creating
what
a
we're going
crisis.
through right now. Yes.
Not higher cost, but huge cost.
Funding?
Higher and huge. We have an exercise we're going to do that will show exactly how that happens.
I think there's also waste and flaws in the system. I guess we're saying a lot of that, but I'm thinking of, for example, that there's a shortage of family doctors, but then they'd set up nurse practitioners in remote communities for the, and that's much cheaper and a good satisfaction from the evaluation. So I don't know how, that's one example of a flaw, but there's many other flaws just in the processes and how it's delivered. And that applies for other, we're not using the best skills of our workers to advantage.
That's right.
They're untapped. These people, many health professionals have much more potential and skills, but they're not used. Sometimes it's a power, it's sort of the old doctor thing. It's medical, biomedical versus holistic, and looking at social workers and others on a team that have more to offer, physiotherapists, pharmacists.
Yeah.
Inequity.
Pardon me?
Inequity.
Yeah.
Yep.
Also, it's on your own.
So it's on your own. Can you, what do you
It's
mean?
on
by
your
that?
own healthcare. Because if you can afford services,
Yep.
if you can't, then you're on your own.
Yeah, for sure. So it's 11:30. So we're going to introduce Hugh Armstrong at this point. Are you ready, Hugh? I'm going to introduce you. Hopefully you're here and you're ready. Can you just let me know? Okay. So Hugh is a distinguished research professor and a professor emeritus of social work, political economy, and sociology at Carleton University. He is an expert on health policy, workforce issues, long-term care, the political economy of health, women and work, and much more. Over his more than 40-year career, he has published dozens of books and peer-reviewed articles. He has lent his expertise and his voice in op-eds, testimony before legislative committees at multiple levels of government, to the City of Toronto's work in reforming long-term care, on civil society and academic organizations. He is profoundly generous with his time, and he is a board member of the Ontario Health Coalition. We are so pleased to have him. Welcome, Hugh.
Hey, Linda, before we go on, listen to him, can we have people turn off their mics?
Yes, yes, we take care of that, so it's all good, Lance. Yes. Everybody turn off your mics. Well, except for Hugh. Hugh, you can turn yours back on, please.
Fine.
There, okay.
I have a very wonky computer. It now spells me H-U-G-E, but it really is H-U-G-H.
Okay.
And I'm happy to be here. Thanks for the intro. It's an honor to help contribute to the legacy of Derrell Dular, with whom I had the privilege of serving on the Ontario Health Coalition board for several years. My task today is to help make the case against privatization in healthcare. In one sense, this is very simple. We know that for-profit care usually means lower quality, more precarious jobs with less pay and fewer benefits, more resources spent on administration, and less effective regulatory oversight. In another sense, as we've seen in the discussion, the brainstorming just now, privatization is complicated. In my few minutes, I'll offer two analytical frames for examining privatization. The first is its many forms. And the second is the basic criteria for assessing these forms. First, the forms of privatization. The most prominent forms concern who pays for and who provides or delivers the care. The privateers know that we want healthcare to be free at the point of service. We would much rather pay for it through our taxes. Any visible move to private payment is known by Canadian politicians, from Harris to Harper, from Ford to Kenney, to be for them a dangerous third rail. In a stealthy move, however, right-wing politicians and their supporters claim instead that we don't care who delivers the care. And sometimes, in desperation, we don't care. If a surgical procedure, for example, is unavailable through Medicare, or if the anticipated wait time for it is deemed excessively long, some are prepared, reluctantly, to pay privately, and perhaps to go into debt to do so. Some may even join patient groups funded by the drug companies to lobby for expanded public payment to treat their specific condition. The connection between who pays and who delivers can be illustrated by the example of super expensive drugs, some with very limited or no additional value, and not covered by provincial drug formularies. In the pandemic context, another example would be PCR tests needed for school, work, or travel, but accessible quickly only through private purchase from their manufacturers and deliverers. In long-term care, an illustrative example is the employment by family members who can afford it of private companions deemed needed for their residents. On who provides, we happily have very few for-profit hospitals in Canada. But the story doesn't end there. As public funding for hospitals and doctors is cut back or was not comprehensive in the first place, insurers rush in. They offer out-of-hospital coverage for drugs, rehab and other therapies, mental health services, home care, and so on. Even doctors' notes. About 30% of healthcare costs are borne either by individuals out of pocket or by mainly private insurers, revealing again the connections between who pays and who provides, as we are held responsible as individuals and families for more of our care. There also exist several other interconnected forms of privatization, and I will just list them briefly. One is the contracting out by facilities of specific services, not only food and laundry, but also building maintenance, security, and even management. Decision-making can be moved to outside consultants, often employed by large firms like KPMG and Deloitte. Business practices, such as just-in-time delivery or continuous quality improvement, and business language, such as bottom line or business plan or customer, can infect public institutions. Perhaps most insidiously, care work can be sent to another type of private, the private household, where the work is done primarily by unpaid, generally unrecognized women. I could elaborate on the forms at length, but will say instead a few words about criteria. Conventionally, students of public policy consider three main criteria: the quality, the efficiency, the accessibility of a proposed or established policy. There are often trade-offs to consider. High quality, for instance, can come at the expense of cost efficiency and or universal accessibility, as the US system demonstrates so starkly. Some Americans receive excellent insurance-funded care. Others get poor or no care. However, privatization fails on all three of the criteria I've listed. Take quality. For-profit nursing homes usually have higher rates of infection and death, of hospitalization, and of verified complaints than do their nonprofit and municipal counterparts. This should come as no surprise, as they and for-profit firms throughout healthcare spend less on staffing and training than do the nonprofit and public entities. And they divert revenues from care to the pockets of senior executives and owners. For-profit organizations tend to cost more. In their pursuit of profit, they and their public funders incur much higher transaction costs. The presumption of dishonesty means that both parties to a contract, all three or more parties in a P3 contract, must have their own staff and detailed documentation in order to keep a wary eye on each other. Then there is accessibility with its equity and equality implications, negative implications. I'll leave it to Paulette to focus on these important negative effects of privatization, especially for women here and across the globe. Instead, I'll mention a fourth criterion that we could and should invoke, and that was mentioned briefly in what immediately preceded this presentation. Ownership and operation in long-term care and elsewhere are obscured by multiple layers, with holding companies, real estate investment firms, franchised operations, partnerships, and subsidiaries of various kinds all involved. These make the attempts to regulate for-profit firms both more necessary and more detailed. Such attempts are often quite futile as well, and are typically aimed at staff and specific homes, not at the underlying structures, such as funding arrangements, credential provisions, government policies, and so on. The pursuit of profit conflicts with accountability to and direction from the public. I'll close by reiterating that privatization is complicated. It's gray and fuzzy, as somebody said just now. It has many intersecting forms and negative outcomes. I'm offering today some analytical tools to help us combat it. But privatization is also very simple. As Nancy Pelosi of the US Congress put it, speaking about attempts there to, by those who would impose privatization on Veterans Affairs, and this is a quote, they don't want to make it better, they want to make a buck. Thank you.
Thank you very much, Hugh. Very much appreciate it. So we now have a few minutes for questions, people. So if you want to go forward, just put your hands up. And yes, and I hope you see the applause. Some people are very busy applauding you, Hugh. So I can see that on the side and giving the thumbs up on your presentation. So for questions, if you could, put your hands up so we can see you. Anybody have any questions?
Linda, I'm going to let you recognize people and maybe group a bunch of questions, and then I'll try to respond.
Okay, yes, I'm looking for, I don't see anybody's hands up yet. Am I missing that? Going to the top.
I saw Dot Klein's hand up for a minute.
I see Lance Livingston. You have a question?
Yeah, quite a few years ago, I was at a meeting to do with and they were talking about trying to think of the name of the groups. It's what they do when you're in the hospital and they have them all over Ontario. There's so many groups. It used to be just a certain thing. My mind's not connected to it, but it's not important. But so they were talking about the need to build more hospitals in certain areas. And so I can remember questioning them, how are you going to build more hospitals when you don't have the nurses now, because you laid off nurses? And the reason why you laid off nurses because you wanted to cut costs. And how you laid them off is you cut beds. If you open up all the beds that are in the hospitals not being used, that would give you a lot more beds. And but you need to hire nurses. So the main thing is, I think they wanted to get privatized hospitals, and that was the start of it. Is when they did that by cutting beds. So how can we get them to start opening up the beds that they've cut in hospitals?
Okay. So the question is, how can we get them to open up beds that they cut? Okay, did you get that, Hugh? So I'll go to the next one. How can we open up beds that they cut? Okay, the next one I see is Dorothy Klein.
Yes, Hugh. I came into healthcare before OHIP. Worked for the Victorian Order of Nurses in rural communities and in the north. And of course, I continued as the Ontario Health Coalition, or the OHIP expanded, but I saw privatization come in. Specifically, it started in the early 80s and into the 90s, of course, and that's where, Lance, we started to lay off nurses. And nurses, once you lay them off, they don't keep their competency up and they have no work and they go on to other things. So it isn't just a case of opening beds now. We do not have the resources, the supply of nurses. We do not have, and to train them, it takes the 4 years, and then to mentor them. I'm asking you, because you've been around as long as I have, how do you think, or what do you propose that we do now to, because I worked in long-term care. I know exactly what's going on. I've worked in community, I've taught nursing, I've done all of the realm except work in the jail. And I really know that we have to collectively start to come together, and I mean all areas of our population have to come together to really start to make short-term plans, long-term plans, and really get the energy behind changing. We've done Band-Aids all over the place, and they've all fallen off. And look where we are.
Okay, so how
I would like to ask that.
Okay, so how I hear that, Dorothy, is that how can we, start by coming together and building the plans that we need? We've been waiting a long time. So how do we get the energy and get the changes that we need? Okay, so Hugh, there's that one, and I'll try one more before Hugh answers any. Carol, I see your hand up.
One of the problems in long-term care has been the lack of accountability that people have brought up before. It's the long-term care places were not fined, have not been held to standards, don't get the same reports, don't have to fix things in a timely fashion. How have they been able to get away with that? And how can we put a thumb in the dam at that part?
Okay.
Natalie, can I ask a question that's related to what Dot just asked? And I think when she talked, because I've had a lot of nursing experience the same as Dot, and I think a key question, we focus on hospitals and downstream reactive. What about prevention, health, moving upstream and looking at what are the real social determinants of health? So poverty, we know undoubtedly the lower income families use more healthcare services. They have poorer health outcomes, and
Leanne, we are only going to have 2 minutes now for Hugh to answer.
Okay. All right.
So I'm just going to move Hugh, if you can answer the first two questions. I don't know if we're going to get to any more.
Okay.
Because
Thank you.
we're on a very
I'll do what I can.
timeline. Sorry,
And I'll focus on the
Hugh.
staffing issue.
Okay.
The staffing issue is longstanding. Some of you in Ontario will remember Mike Harris, who talked about nurses going the way of hula hoops. Some of you will remember after the SARS crisis, especially in Toronto, that there was mention of the need for the use of the precautionary principle. Some of you will remember there was a lot of talk a few years ago about making hospitals and long-term care more efficient. What efficiency means is that you offload the costs to someone else. Whenever you hear efficiency, beware. The same could be said about all the preventative things and all the social determinants of health things. I will instead simply focus on staffing. You're absolutely right. It doesn't make sense to have more spaces. I don't like calling them beds, if you don't have the staff to work there. A couple of things about that. The conditions of work are the conditions of care. You'll get good quality care if you've got enough and enough full-time and enough trained staff to do the work. So we have to focus on staffing. In doing so, we've got to get rid of the legislation that limits pay increases. We have to keep the restriction on workers moving from site to site because they are only vectors for more disease. We have to ensure that we get rid of agency workers. We have to figure out how to make more the Health Coalition says 70% in long-term care should be full-time. The others, the part-time, should also be permanent and should have prorated benefits and be available to fill in for the full-time when there are vacations and education leaves and so on. So there are a number of things that we should be doing right away to get the hours in long-term care, to get the hours up to 4 per resident per day. The government is saying they'll do that by the end of, they'll get it up to 3 by the end of March. I don't trust them. So to go to Carol's question as well, we need to insist on more accountability, more transparency. In other words, what we need is to continue what we've been doing up till now in advancing through the Health Coalition and in other ways, through family councils, through unions, through whatever. We have to increase the pressure on the current government, whatever the government is. And I too am nonpartisan. The Liberals made a mess of it before the current Ford government came in, and the NDP didn't do terribly well either, because they were all locked into, in various ways, to various degrees, the neoliberal notion of cutting public services, of austerity. We've got to move away from that as quickly as we can, involving as many residents of Ontario as we can. I'm sorry to be so long. I'll leave it at that and welcome a few more questions.
We are now out of time for questions. I'm so sorry, right? But, you know, we have to move on to our next. So Hugh, I just want to say again, thank you so much for participating in this educational event. Your information is very important, and we continue moving forward together to make the changes that we need. And hopefully we all do have the energy to do that. Okay, thank you, Hugh. All right, everybody, sorry about that. It's so hard to continue moving away when I see that there's more questions. So, but we need to move on. So where we're going to now is we're going to do a visual. Are you ready? First of all, I need to know if my co-facilitator, yes. Okay, and he's already picked people. Good job, Patrick. So what we're doing now is we're starting an exercise. That's a visual exercise. And this is a new experience. So we'll see how this goes, right? So it's something that you also be able to do if you're going to take this educational home once you get the notes, and you can participate. So when you go to do this exercise, you need to be host, and you need to be in the immersive view. So I'll just leave it at that, and we'll go into doing the exercise. So who has ever heard people complaining that, you know, or saying that private healthcare is more efficient? Anybody ever heard that? You know, or wealthy people who say, I should have the right, if I want to pay for my care, I should have the right to do it. If I don't want to wait, I should have the right, that I have the money, I can afford to pay, and I should be able to just do it. Anybody heard that? I know I sure have. Yeah, so Patrick, I see a big dark circle, so I take it that is a person. Patrick?
Yes, I'm trying to put another person there. I'm trying to figure out how to do that.
Okay, all right. So we have our 6 volunteers. This person, I don't see their name. At the very far right, I'm not seeing any names. So who is this person with the glasses on at the very far right? Because this person's going to be our doctor. So names aren't showing up for me here for that. Do you have a name for that person?
Unfortunately, that's not showing. So we can just move
okay,
along.
I'll try and work without the name. All right, so the person on our far right of the screen who has a black top on, does she know she's in there and she has glasses? right? She is going to be our doctor. Do you know that you're going to be our doctor?
From description, it's Joan Lynn. I have a black top with glasses, but I don't know that I'm in there.
Well, no, that she's not speaking, so it's not you. Her mouth's not moving anyways.
Am I in this group?
You are. I see. Oh, you're on the left. Are you waving? And you have a moon? Yeah, so you're on the far left. So no, you're not the doctor. Oh, that person. No, somebody else is the doctor, Patrick.
Okay, so on the far left. Okay, I'm sorry. I'm getting my left and right confused here.
Okay, so on the far right is a different person now who's going to be the doctor. You've moved people around. Okay, so who is that?
Bonnie.
Bonnie, thank
Bonnie.
you, Bonnie. So Dr. Bonnie, are you ready?
I'm not sure what for.
Yes, it's all good. So you're going to be very busy. You're going to be taking care of all the people, which would be to your right, but to Patrick's and I's left are going to be people waiting in line to see you. Okay, Bonnie?
Yep.
All right, so they're all waiting in line and they've been triaged. So they're waiting in line, but they're waiting in line in order of their need for care. And you're a technologist, doctor, whatever this is an MRI lineup, right? A scan. MRI is, a scan for anybody here who doesn't know. Okay. So the resources and our radiologists and doctors are scarce because it takes, look at this, you're great. He's got a mask on. Good job.
And social distance in this boardroom. Yep.
Yes. That's great. So yeah, the resources are scarce. It takes 10 years to get to be a radiologist. So we don't have tons of them. And it takes time to get more. And it's the same for every country. It's not just Canada. So the 5 of you who are in the lineup for MRI, because we have a public health care, like I said, you're lined up based on medical need or medical priority. Okay, so the first person after Bonnie with the mask on is really in trouble. He has a terrible head injury and he's having frequent seizures and isn't able to speak. He needs an MRI right away. Put him down, please, Patrick, because he's in the public lineup. Thank you. So yes, I see what you're doing. The second person, that person there, thank you, Patrick, is also seriously in need. Not as serious as the guy with the mask on. He's doing great. Thank you. Thank you so much. But needs to get in there today or tomorrow. The third person can wait a week or two, right? That's the person. Yes, right. This person can wait a week or two. The fourth person, that big black circle there, it's not urgent at all. They had a baseline scan a couple of years ago and they need a follow-up every couple of years. So that's why they're waiting for that scan. And the last person in line, yes, really does not need an MRI. They are a hypochondriac and have been bugging their doctor. And so Bonnie put them on the list just to get them off her back. Yes. So this is our lineup. And again, because we have that public single tier healthcare system, based on need.
So she knows I'm the lady in the cat.
Yeah.
To identify
From the neediest and most urgent to the least needy and least urgent. And this can happen in any system where the lineup is not based on how wealthy you are. And, and this is where, we like to see this go. So
I'm like 2 weeks in.
Okay. So anyway, yeah, you're 2 weeks, but you're getting antsy, this person at the back of the line. If you can, we just lost the seating. Patrick, are you still there?
Yeah. Okay, hold on. He's got to fix it. Patrick's got to fix it.
Yeah. Patrick?
I think Patrick might have disconnected. I think that's what happened.
Oh, he disconnected. Oh, no. Oh, God. You got to love when that happens.
Right.
Can you make me the co-host and see then?
Yeah, 1 second.
Okay. Just let me know, so then I'll go to view. Sorry about that, everybody. I don't even know if I'll get the same people, right? Oh.
There's mute. You're on
Okay.
mute. But I don't know about here.
Okay, hold on. Let them fix it.
Okay, so
Might
what's
not
the
be
first? I have different people. What's this? I've married. Can you see that? Oh, here we go. Well, this is good. Where did Bonnie go? Bonnie, I'm putting you back in where the, I don't know if I can do that. There you go, Bonnie, you got to be the doctor.
Okay.
Okay, so Bonnie's back being the doctor. So I'll try to do this and facilitate at the same time. Okay, so this person at the end, I don't know her name. She's very well off and she doesn't want to wait, right? So she wants to, you know, pay for care. So she has $1,000 and she's going to use that $1,000 and she's going to, see if I can move her. She's going to go and jump the line and get ahead. And
There I
even
am.
though-
See, she's gonna jump the line.
and, yep, and even though she doesn't need the care at all, and the guy with the head injury is in desperate need, she's got $1,000. He's only paying, the public health care is $350 at this point. So, you know, so Bonnie and who likely would Bonnie be serving? Would she, because she needs money too. So she gonna go to where the, we'll just forget who Bonnie really is. Is she going to go to the one who's only going to give her $350, or is she going to go to the person who's going to give her $1,000? Right?
No.
She's likely going to go to this person right here. You know, so now this
No, I'm
person
not.
has jumped the line, and everybody else here, right? Guess what's happened to them?
But I wouldn't do that.
I know you wouldn't, Bonnie,
It's
but today you
immoral.
are.
It's immoral.
Today something bad's happening and you've just changed, okay?
No way, Jose.
So yes, and then, you know,
Point
this
out.
person, you know, with a, who's now at the end, she wants to get some service too. And you know what? She's willing to pay $1,500.
Oh, jeez.
Okay. So guess what happens, right? Everybody in the public line who doesn't have that money, who actually needs the health care first, right? It's now.
Look at him, he's
not
crying
late.
because of the head injury. He's not getting it first.
So this is what happens. So, you know, so in order for public health care to compete, right? What is going to happen? They're going to charge more. So this radiologist is still going to want to service the public health care people. They're now going to have to pay $1,500. Do you understand how that works? That's competition, right? You know how they say competition makes everything better? Well, this is competition. And so now the healthcare is now going to cost way more, and it's not going to deliver anything any better because Bonnie was already giving the best care that she could. Dr. Bonnie was already doing that. Do you see how that works?
Mm-hmm.
Does everybody see how that works? You know, so have the costs gone down? Everyone? No, they have not. They've gone up, right? Has service become any better? No. In fact, it's become worse for the people who need it the most. Right? So this is how to do, yes, that's right. Thumbs down. This is how to show, and I can't see the time. It's 12:04. This is how to show all of us in a very easy.
What's he showing his American Express?
card. But very well done. You picked a winner when you picked him, Patrick. Yes, thank you for that. But yes, if you don't, healthcare becomes run by a credit card, right? And so it is very unfortunate. So yes, this is the exercise that shows, and hopefully everybody will better understand what happens to the wait line when when people, you know, get to say, okay, I have the money, I should be just able to jump. There's only so many staff. There's only so many people that can provide this care. So it's not like there's some kind of miracle or the wait lines are going to be shorter. They're not shorter. The same amount of people need care. The same amount of people are providing care, and the same training is required. And so all privatization does is provide a two-tier healthcare system that works for the rich and doesn't do, you can think of the bad words that are in my mind, doesn't do much for anybody else. Okay? All right, so thank you for our volunteers. And it's now 12:06 and it's lunchtime. So if everybody can go have lunch and be back at 12:45, right on. We're going to start on time.
Oh, we got a nice, like, over half hour.
All right, and thank you so much for everybody this morning. It's been great, and the afternoon should be just even better. Take care. Have a great lunch. Back at 12:45.
So do others on this call have other specific areas where it would be beneficial for us to find resources to help educate the public and members in each of our own communities? Let's see. Yeah, people can, I suppose it would be best if people would raise their hands so that I can see them in the be able to recognize them right away. So if you know of other resources, please raise your hand. So I see Bill. What other resources? Oh, did you have your hand up, Bill?
I did for a different reason. The only thing, okay. You said you sent this information out in our package, but I don't know that I've received it yet. And that was my only comment. I don't have anything to add to your list yet.
Okay, I will definitely make a note of that. And
Patrick, it's Linda. Everyone is going to receive this. Everyone will receive it. Yes.
Okay.
So everyone who's participating today,
yes.
Yep, everyone who is participating today will not only get the full information package, but also the notes and things that the facilitators had and notes on the discussions that our speakers gave today.
Hi, Patrick. It's Karen Henderson. I can't seem to raise my hand. It's kind of disappeared, but I've got a ton of resources, just gazillions of them. It would be helpful if somebody were to post a list of categories under which that we could look at and say, okay, I've got a resource for this category or that category, instead of trying to guess what you think you would like.
Excellent note there. I'll see if I can get. So what I'll do is once we're through this discussion, before we go back into the plenary, I'll post topics from the Ontario Health Coalition website to give us a good sense of what we're looking for. So the next person who had their hand up is Hugh.
Oh.
Hugh Armstrong.
Yeah, let me add some other free items. They are available from the Canadian Centre for Policy Alternatives.
Oh yeah.
Policyalternatives.ca. I'll mention two of them. One is called Investing in Care, Not Profit. It is co-authored by me, by Pat Armstrong, by Alex Himmelfarb, and 6 or 7 others. Investing in Care, Not Profits. The other one, which is the summary of our major research project on long-term residential care, is called Reimagining Long-Term Residential Care, also available from Policy Alternatives. Thank you.
Outstanding. Thank you very much, Hugh. But next I see Ann Colley.
Yeah, Skajewski Coley. Okay.
Sorry about
you're
that,
on
Ann. There we go.
Can you hear me now?
We can, thank
Can you
you.
hear me? Okay, I would also check the National Lobby Group of Disabled People, CCD. They're based out of Winnipeg. The Canadian Council with Disabilities, I believe. And they would probably have all kinds of resources about healthcare impacts on persons with disabilities. Disabled persons. So I would check there, and I would also check in Ontario any of the lobby groups of disabled people, not for but of, right? So consumers themselves, not service providers. So they would have
and
share information.
yeah, and the Canadian Council that you mentioned, could you say that again, please?
I think it's the Canadian CCD, so it's Canadian Council of Persons with Disabilities, I believe, is their full name. So there is the National Lobby Group. They actually lobbied to get disabled people included in the charter in the early 80s. So they would absolutely have stuff on healthcare decisions. So they lobby the federal government on the impact of laws and legislation and their impact on disabled people. So that would include transportation, housing, healthcare delivery, all that stuff. So I'm sure that they would be an excellent resource.
Fantastic.
And then any other provincial organizations of disabled people, they may as well. So I'm not sure which ones in Ontario would be, because but they would, or the member, or you can find out from CCG who the member organizations, provincial organizations of disabled people would be there. So if you're in Ontario, I'm not sure what the grouping is. I worked for them for many years, many years ago. Anyhow, so that's what they do, is they advocate. They're an advocacy organization that monitors legislation. Federal legislation.
Outstanding. Thank you very much for that.
Okay.
And just as a reminder that at precisely 1:45, everyone is going to go back into the main group. So even if we are in process of having a discussion, everyone will be moved off. So hopefully that'll happen automatically, but we see what happens when things should be automatic. That just means that Sala has to work really hard. So bear with us on that. And again, I apologize for earlier. I dropped off. I hit the wrong button. So I'm terribly sorry, but it did look like the things went well. So getting into our next speaker, we have joining us Paulette Senior from Oxfam Canada, and Paulette is the Ontario representative to the Oxfam Canada Board of Directors. She's also president and CEO of the Canadian Women's Foundation and a sought-after commentator on gender equity, gender-based violence, women's poverty, the wage gap, and girls' empowerment and leadership. The Ontario Health Coalition Executive Director, Natalie Mehra, has been deeply impressed with Oxfam's work on growing inequality, public services, and taxation, and really wanted to ask Paulette if she would come and share her perspective and the expertise of Oxfam. We are excited that she has agreed, and we are so happy to give her a warm welcome. Welcome, Paulette.
Thank you, everyone. Great to join you this morning, and on this rather cold but beautiful morning here where I'm located. And thank you to the Ontario Public Health Coalition for inviting me to be a part of this critical conversation today. But before I get started, let me add my acknowledgements that I'm coming to you from the traditional territory of the Mississaugas of Scugog Island First Nation and Williams Treaties, signatories of the Mississauga and Chippewa Nations, just here in Pickering. However, I recognize that land acknowledgements are not enough in terms of removing systemic barriers that are facing Indigenous peoples. At the Canadian Women's Foundation, where I work, we know that our pursuit of gender justice is tightly intertwined with the pursuit of truth, reconciliation, decolonization, and allyship. As we do all our work, we are committed to prioritizing these principles in our practices, our advocacy work, our strategic planning, as well as organizational culture. And as the leader of an organization, the Canadian Women's Foundation, to advance gender equality, I know how important it is to ensure equitable access to quality healthcare and other public services. The pandemic has only widened existing social gaps and made it clear how many holes there are in our existing social safety net. In fact, we know that 87% of economists expect inequality will only increase as a result of the pandemic. And as someone who sits on the board of Oxfam Canada, I would certainly want to echo the points that have been made about services like free public health and education as having a key role in addressing poverty and inequality. Here in Canada and certainly around the world, these services certainly need more investments, not less, if we are going to be able to address future crises like pandemics and climate change. And so as I deliver my few comments to you this morning and share them, I am also speaking primarily as the leader of the Canadian Women's Foundation, of which this issue is critical to the work that we do throughout Canada. And for those of you who don't know the Canadian Women's Foundation, let me just give you a brief overview in terms of the comments that I'm making as it relates to the issue of privatization. The foundation recently marked its 30th anniversary of being Canada's Foundation for Gender Equality. We provide funding to programs that empower women, girls, two-spirit, trans, and non-binary people to move out of poverty, out of violence, out of poverty, into confidence and leadership. Our efforts are fueled by people just like you and others, by good thinking, forward thinking corporate partners and government investments in advancing gender equity. This support enables us to fuel change in 4 critical areas that we work in, not just change for the long term, but also as we have been going through this pandemic, including ending gender-based violence, ending women's poverty, building girls' empowerment, and building inclusive leadership as well. And I'm proud to say that we prioritize funding that serve individuals and communities who remain underserved and probably the hardest to serve and reach. This means programs that serve women with disabilities, Indigenous folks, Black and racialized women, newcomer women, women living on low incomes, etc. And our work at the community level informs our efforts to advocate for systemic change at the national level. Ever since the pandemic started, we've been focused on raising awareness of its disproportionate impacts on women, particularly those who are from marginalized communities, and advocate for the long-term strategies and policies that will help them recover. Overall, the pandemic has shaken decades of progress towards gender justice, and movement toward privatization of healthcare would only set us back further. First of all, when we look at who contracts the virus, it's clear that underlying social inequities play a key role. Data from Toronto and Ottawa indicate that COVID-19 cases are 1.5 to 5 times higher among racialized versus non-racialized populations. Social determinants of health, including income, gender, race, ability, immigration status, and culture also influence access to vaccines, COVID testing, and even the PPE needed to contain the virus. And beyond the direct health impacts, diverse women have also borne the brunt of the pandemic's economic impact in terms of job losses and workforce attrition. They're carrying a heavier burden of unpaid caregiving, and many are living at higher risk of abuse and violence because of the necessary social restrictions. Research has also shown that women's mental health has suffered more than men's. In fact, a poll that we did at the foundation last year indicated that almost half of mothers were reaching their breaking points. I'm sure those of you who've paid attention have heard of these stories. We know that all of these impacts have been more acute for women facing intersecting forms of discrimination, such as racism, ableism, homophobia, and transphobia. And pandemic restrictions also make it harder for all women to access services and supports that could actually help them. And now that I've given an overview of the gendered impacts we're struggling to deal with, as it is, it's difficult to imagine how our pandemic recovery would look with a privatized health system. So as we look to the future, it's clear that if we are to shock-proof ourselves against future crises, we simply cannot go backward in terms of our social safety net. We need to actually aggressively advocate for public funding of services and supports that leave no one behind. This is funding that goes beyond what our health system currently offers, but is nonetheless critical to ensuring equitable access to public health. The foundation has released a series of reports called Resetting Normal, which offer a roadmap to pandemic recovery centered around gender equality. Two of the key lessons from the reports are that, one, community care is an essential service that needs much more funding, and two, that inequity is harmful to our collective health. So let me expand a little bit on these points. Before the pandemic, the term essential services was generally thought to mean first responders such as police, firefighters, and emergency room doctors, along with municipal services like garbage collection. But as the pandemic quickly revealed, keeping people safe and healthy also depends upon long-term care and home care, child care, and women's services such as emergency shelters. These community care services are critical to gender justice, since most of the people who need them are in fact women or parents, as are most of the people who deliver them. So despite the critical need for these services, community care across Canada has been underfunded for decades. In most provinces, services are a confusing mishmash of public, private, and nonprofit delivery. And while it's promising that recent federal policy responses have included a long-awaited push for a national childcare system, and I mean long-awaited, we must keep pushing for such essential community services to be realized. It certainly is a message that we're bringing to all elected officials from all parties in Ottawa. And when it comes to the second lesson, that inequality is harmful to our collective health, the pandemic has shown that our public health measures are only as powerful as they are inclusive. So allowing the continued destabilization of community care would harm the most vulnerable, be disastrous for women's equality, and actually endanger the health and safety of the entire community. Resetting normal to us means ensuring a well-funded system of community care. Resetting normal means taking steps to address historic inequality, because social and economic equality is not only the right thing to do, it benefits everyone. Resetting normal means listening to people who are not usually heard wherever community decisions are being made. All of these priorities are at odds with privatization, and the time to reset normal is now. So I'll wrap up by saying that if you're interested in learning more about the reports I've mentioned, I invite you to check out our website at canadianwoman.org. And I look forward to the discussion ahead. Thank you very much.
Thank you very much, Paulette. It's fantastic work that that you and Oxfam are doing, along with the Federation. Let's open up the floor here for questions, and if we could follow along the same tact that let's take a few questions. Please raise your hand. I see Ann there. We'll take a few questions for you, Paulette, and then if you could answer together. Fantastic. So I see Ann, and anyone else who wishes to ask a question, please raise your hand, and we'll get to that. And so right now, Ann. Up, you're on mute, Ann.
Thank you. I love the gender analysis on all of this. This is fantastic to hear. One question, whenever we talk about childcare, public funding for childcare, I also think of women who stay at home to look after their family. I've always had to be at home because I have a son with who's autistic and requires constant care and supervision. So there are also women who might want to stay home and raise their families. And we're always, for people who are progressive and left-leaning, we have allowed that conversation to be completely dominated by the right? And I'm just wondering, is there any analysis of women who are at home in terms of their mental health and their stress levels? Because I think about women who are working and in the paid labor force. And then on top of it, like, we know that women carry 70% of the childcare and home care at home, which adds to their stresses, right? So because they don't have one job, they have two jobs. We still, in this day, 2022, still do not recognize the work women do at home, and extending care or financial supports, not just to daycares, but to women or a father. I mean, there's lots of stay-at-home dads too, parents who choose to be at home and are foregoing income.
Excellent. Thank you very much, Linda. And we have two more questions. Lance?
Yeah. Question about my question is about is the COVID created a problem for women? And the reason why I'm asking that is because I'm not saying these are just stay-at-home moms. I'm just saying these could be working moms, and they do a lot of work at home, just like what Ann said. But when COVID hit and a lot of jobs were lost, a lot of them were women that lost their jobs, and the kids were at home now all of a sudden, and then the men end up getting laid off and not working or whatever, staying home. And I think what happened is, I'm not saying all the homes, but all the things are going on, but I think the men weren't used to even being at home with the kids and the wife and the whole bit. And I think that caused a lot of stress in marriages, and why there was a lot of more abuse to women. and kids. So I want to just know if COVID was a big concern to what happened on this issue.
All right. Well, thank you very much for that, Lance. Next question. We'll go ahead and take Malcolm.
Yeah, thank you, Speaker. Yeah, I really appreciate your comments, Paulette, and thank you very much for the presentation. There's no question that COVID-19 adversely affected women greatly, and their families, and their children in particular, and their jobs. They were victimized 3 or 4 different ways, and it was horrendous. However, also their healthcare needs were adversely affected. No question about it, and Lance has made those comments quite clear. So what are we going to do about this? I would certainly appreciate your comments about how we, in this June the 2nd, provincial election here in Ontario, we have the opportunity to raise our voices, raise our political action to make a significant change. We have to expose those individuals and groups and politicians who are advocating the privatization of healthcare, all aspects of it. We can't just sit back and say, oh, well, we're, you know, it's all very nice and we've got to move forward. We don't upset the apple cart, as it were. So I'd really appreciate your views about how we collectively, come June the 2nd, mobilize our forces to stand up for public, effective, quality healthcare in this province.
Excellent.
Really appreciate your comments.
Thank you very much. And one last question from Dorothy, and then we'll turn it back over to Paulette to try and shed some light. Dorothy?
Yes, Paulette, thank you very much. I want to build a little bit on Malcolm's that's just spoke before me. I've been in healthcare since I was graduate nurse since 1965. I'm still, and this is 57 years, and I'm in Northern Ontario. I'm in Sudbury. I've worked all through the North and the South. Anyways, what I want to ask you is, how do we mobilize all of our forces, not just Ontario Health Coalition, but all of the things that you spoke about? It's been around for a long time. And when I first started into nursing, we had Indian hospitals. And if an Indigenous person came to our hospital, we turned them away unless we had a bed. And not only that, if we had a bed, we had to get the permission of all the other people in the room to give them care. And I'm not talking about a third world country. I'm not talking, but this is, I'm seeing, as we're talking about COVID and where COVID is located and who gets injections or vaccines, who gets what, I see all the same things that I saw 50 and 60 years ago. How do we come together as all the other people that really see this and mobilize and push? It is not just the politicians. The politicians are only kind of dancing to the voter. And so I would like to know if you have any ideas, because I don't have any more ideas. And I'm still here.
That is a huge question. Thank you very much for that, Dorothy. Well, Paulette, there's been a big plate here. Hopefully, in turning it to you.
Mm-hmm. Well, thank you so much, Patrick, but thank you, Dorothy and Anne and Lance and Malcolm, for your questions. I think there is a connected string among all your questions for sure. Starting with Dorothy's points with regards to women who work from home, not just stay home, but work from home. It is indeed work. We've always, as the foundation, see the need to recognize that it is work, it's unpaid work, it should be recognized as work. And so that is our position on that issue. But also that, you know, for women who during this pandemic have been working in and outside the home, still carrying the majority of work in the home and working outside the home, you know, they've been put in a position of having to make truly heart-rending choices with respect to, do I stay home to keep my family safe from this pandemic when there is no, for example, childcare, or do I take the risk? And a lot of women have actually decided to give up their careers and work from home. But you know, without outside employment. So it's been a horrendous situation that many families have faced, that women have had to make that decision because it has been an impossible situation. And so it is beyond time that we in this province certainly have a childcare system that is accessible and amenable to the needs of parents today, and be able to support, while women have been an extraordinary contributor to the economic strength of Ontario. So I think that that needs to be recognized, and it is certainly part of our policy and advocacy positions in terms of all the work that we do. In terms of Lance's question with respect to the impact of COVID on women, you know, that's why we did the Resetting Normal papers or reports that have focused on a number of areas. I mentioned two. The other one is, another is with respect to gender-based violence that you noted, Lance, that we saw an incredible spike in incidents of gender-based violence. So at the beginning of the pandemic, the message that we were all getting as a society is the importance of staying home, right? So everyone got that message. Most Canadians certainly abided by that message. For women who are already living in precarious situation where they're experiencing abuse and violence in the home, that was an extraordinarily vulnerable message to be receiving. It put them in even greater area of vulnerability. And so what we saw from organized shelters that we fund, for example, is that that women were stuck in the home and without much access to leave. And so shelters are trying to figure out how to support women who were in those kinds of precarious situations. What we did at the Canadian Women's Foundation, considering the work that we do is to fund a lot of the shelters, is that we created an online tool called Signal for Help. Hi, Tana, so good to see you. An online tool called Signal for Help. It is a simple, I don't know if you've heard it, if you've been watching the news over the past few months, you would have seen that it was used in a situation in Kentucky, where a girl was abducted, and the use of the signal was very helpful. So it's a one-hand signal that you put up on a virtual meeting such as this, or in other circumstances, you tuck your thumb, you fold your fingers over, and it's what we call the signal for help, right? And so this particular signal actually went viral on TikTok and other social media platforms, and was instrumental in many situations that we've heard about around the world. And so this was our way of creating something that was simple, that didn't leave a digital trace, to support women who weren't able to talk about or use the phone, or the normal ways that they would indicate that they need help, that this would be a way for them to do that and be safe. And then what we would expect from folks who would see that is to find a safe way to actually check in on a person who would use a signal, right? So that's one of the things that we created, because the spike was incredible during the pandemic. It is still at alarming rates. In fact, we know that based on surveys that was done of shelters, that the numbers increased significantly over during the pandemic, and not just in terms of abuse, but also in terms of femicide. So women who are killed by their intimate partners. And so this has been the impact. And so the situation that you described, Lance, where the message for everyone to stay home was certainly drummed into our heads. And so sometimes the reprieve that a woman would have in an abusive situation was her partner going to work. And so this wasn't happening. And so that reprieve was not there. And so that could be part of the reason why the spike also increased. Okay. In terms of, sorry. No.
Oh, I was just going to say, excellent. I thought you had finished there.
I'm almost finished, Patrick, just almost finished. In terms of, I think the last two questions are very similar in terms of Dorothy and Malcolm's questions is what to do. You know, we are in a situation in Ontario that really demands our collective efforts. It demands that we collaborate. It demands that we look at what are the pressing issues that are impacting those who are most vulnerable in society. So if we look at the fact that healthcare is critical and has proven to be a very critical issue, and access to healthcare, access to resources, issues around poverty, issues around exclusion, discriminatory practices, that I think it is past time for us to actually work across issues. I'm suspecting that a lot of people on this call have been advocates at one point in their lives or other in terms of the work that we're doing. I'm certainly an advocate. It's an important aspect of the work that I do and the life that I've lived. And so I think it is important that we do some cross advocacy issues collaboration, and so that we can support each other. One of the things that we're doing at the foundation is we had a pretty poor track record in terms of funding issues in Northern Canada. We weren't able to get folks from the North and remote communities to have access to funds. And so we had to look at a different way of doing that. But part of the issues in the North is also about access to many things, countless things. But one of the pressing issues for them is climate change. And so we've been working in our box of gender equality, but climate change impacts gender equality, right? And so we can't work in a box anymore. And I think it's the same for issues around the privatization of health, is that we can no longer work around that, because I think the pandemic has revealed to us that what's really important is that we have to work across issues. And so I think that's what it calls for. And that's what I would encourage that we look into in terms of the work that you're doing, the important work that you're doing. Thank you. Thank you, Patrick.
Okay, so hi, it's Linda. And I just wanted to thank you, Paulette, for being here. I have been a longtime supporter of Oxfam, so it has been a real honor to see and have a representative of Oxfam from here. So thank you so much. So we'll move on to the next parts of the agenda. And I just want to mention, before we introduce our great Natalie Mehra, that, while we should sit back and start thinking about who benefits from healthcare privatization, because following Natalie's presentation, we will be talking about how we can get this information out widely in our communities. So Natalie, I think most people know her. I have known Natalie for decades, actually, for many decades. I've worked with her in different situations, as well as formerly being on the board. So Natalie, thank you so much. And I mean, Natalie has organized all this, but Natalie, welcome. It's your turn. Your time for your presentation.
Thank you so much. And Paul, that was amazing. That was really, really interesting and very helpful. And so I really, really appreciate the contributions that we've heard today from Paulette and from Dina as well. From Paulette. I'm sort of a little scattered here because I have to leave at 1:35 exactly to go to another session. So I'm just going to kind of race through this very quickly. But I thought before the end of the sessions today, it was really important that people understand what the plans, the post-pandemic plans are, or post-election, post-pandemic plans are of the Ford government, and what we need to look at for the other parties as well as we're heading into the election. So we're, what, 5 weeks, I guess, away from the drop of 4 months, I guess, away now from the election. And the Financial Accountability Office of Ontario, which is, it's a body that reports to the legislature. They're kind of like the Auditor General. They're like an independent body, independent of the civil service and of the political parties. And they give sort of nonpartisan reports and analyses about financial matters, so budget matters for the province. And in their recent report, which looked at the provincial budget for this year, so the 2021 provincial budget, they really laid out very clearly in the kind of unemotional terms of accountants what the plan is for the Ford government in terms of privatization and in terms of fiscal policy. So we know that Doug Ford has a whole array of privatization plans for healthcare already. They have written plans to privatize hospital surgeries and diagnostics. They're going to use the cover of the pandemic to say that there's a huge backlog, and instead of paying and resourcing the system to clear that backlog in public hospitals and clinics, they're going to shunt that money over to for-profit clinics at day hospitals, essentially, to do them. We know that they're in the midst of privatizing the majority. So they in their own numbers, they're saying 18,000 of approximately 30,000 new long-term care beds. And those are 30-year deals, 30-year privatization deals. So they're midway in that. And if we don't stop them, then they will privatize an entire new generation of long-term care. We know they passed legislation in the middle of the pandemic, if you can believe it, to gut the existing home care legislation and bring in a new act which sets up a structure to privatize the last remaining public parts of home care. They are privatizing COVID-19 testing and vaccination clinics. They have a plan. They started it underway before the pandemic. And it's still on the table for post-pandemic to close local ambulance dispatch centers, centralize them all into 10. And the paper from which this comes, the document from which this set of recommendations comes, also talks about privatizing them. And so that's the EMS, that's the ambulance services, the paramedic services. And of course, virtual care is being privatized. And along with for-profit privatization of the ownership of services comes for-profit, like out-of-pocket charges, two-tier Medicare, out-of-pocket charges for those services. From the FAO, the Financial Accountability Office of Ontario analysis, and this PowerPoint will be sent to you as well, so you'll have a little more time with it. We know these things to be actual facts, and this is in their own words. They said, this is from their, this is from their June report, which was the analysis of the most recent provincial budget and the budget plans going forward. So in the budget, they say that the economy is expected to rebound strongly with 5.8% growth in 2021 and 4% in the next year. They said, there's a missing word, that Ford's budget overstates the projected deficit by a whopping $7.6 billion. So, they've projected a deficit around 18.7 billion, and the FAO says by all normal projections, the deficit will actually be 11.1 billion by 2023. And their revenue forecast, that is the amount of revenue collected from taxes and resource revenues and so on, royalties and things, is understated by a significant amount, several $billion a year. So why would a government overstate the deficit and understate their revenues? Well, to make a case for cuts and privatization, right? So, and there are indeed very, very significant planned cuts. The funding cuts to public services that they're planning, this is in the FAO's words, this is their terms. Planned program spending, that's funding for all public services, increases sharply, of course, in the pandemic year and the election year, that's this year, and slows significantly afterwards. They say that the budget's planned program spending, that's funding of all public services in key sectors, including health and education, will not keep pace with the underlying demand for services. Ontarians will see a reduction in public services because funding will not be enough to maintain even existing services. So there's no expansion of services planned. It is actually the opposite. And alarmingly, they say that the budget plan relies on prolonged spending restraint to the tune of cuts to 17.8 billion, so approximately 18 billion in permanent cost savings, that's cuts, right? In order to meet the financial projections that the Ford government has put out in their budget. So the only way to meet those projections according to the Ford government's plan, is an $18 billion cut to public services. In context, over the entire Harris-Eves government, they cut $18 billion in revenues. Those were the largest cuts that we had ever seen in Ontario's history and actually in the history of the country to that date. So this is not normal. This is a radical budget that is planning years of austerity and cuts and privatization post-election. And they note that Ford's budget provides no details on how they plan to achieve these things. Okay, so I'm sorry, I don't have a lot of time, but I wanted to make sure that you had this information. It's vital leading into the election. And what we need to do is push all of the political parties. We need to know what is the Liberals' financial plan? Does it differ significantly from the Conservatives? Because I have no idea what it is, none. And, we follow these things very closely. What is the NDP's financial plan? Does it differ significantly? Because if there is not enough funding, and we have dropped to the bottom of all provinces in funding of our public services and programs, we're dead last in Canada, then there is no choice but to cut and privatize. And so we have a job to do. It's urgent. We can do it, and we have to do it. If not us, who's going to do it? We have to push them all on these issues. It's critical. Okay, thank you very much. I got to run, sorry, and I'll see you in the closing plenary.
Very shortly. Thank you, Natalie, very much. Much appreciated. That's important information. So having heard that and thinking about, who's benefiting from a healthcare privatization, where we're going to go finally, and I'm just going to give you a warning here. At 1:45, we will just be removed from any further discussion and put into, well, we'll still be here, but our discussion will be over because now we're going to be back to the main plenary. So how can we get this information out widely in our communities? That's where we're going to end up today. How are we going to do it? And I'm looking for, you may have to help me. I've lost all that. Patrick, I'm looking for hands up. Okay, Elaine.
I'd say letters to the editor are very, excuse me, a very effective tool.
Okay.
Yes, Anne.
Yes, we need to, the elderly are going to be most impacted by this because this sounds like a plan to significantly lower life expectancy. We're at this time, I think it was projected that life expectancy was going to reach 88 years. I think maybe that was for women, but this is going to hugely impact the elderly and they're not going to get this information. So I think what we need to do is we need to aim for people, for their children's generation, and we need to get this out on social media. So print media is just dead. And that skews to an older demographic. We really have to get this out on Twitter, on Facebook. We need to also get it to a younger generation through their platforms, because they're also going to be hugely impacted by all these cuts. We already know they're already impacted. There's a whole generation of young people now that have mental health issues, and they don't have access to their drugs, that they need, or they have to put that money out and they have to wait a year, right? So it's like what was said earlier about applications for Trillium, a lot of barriers. And so that's where we need to go. We need to go where people are.
Okay, so Patrick, I'd also suggest that you add letters to the editor, because that was brought forward as well. If you could, please. Dorothy. Dorothy's next.
We have to get this out to the seniors. The seniors are a very big voting group, and they do not understand. Some of them have some money and they think that they don't have to care about public health system because they have money. They do not know how much they need.
That's true, Dorothy, and there's a lot of seniors that don't have any money too. That is for sure. Bonnie.
I had a couple thoughts. Virtual town hall meetings and meetings with the different political representatives that are running and bringing long-term care to the forefront as a general issue.
Okay, virtual town hall meetings. Now, I think too, Bonnie, that's helpful if, not that we're not all getting tired of Zoom, but if there's something that we have learned, the good part about that we've learned from Zoom, I think, you tell me, is that at least now we can get to people that we weren't able to talk to before, because people don't have to travel. Lance Livingston.
Yeah, okay. We need, this is to do with long-term care homes. And we need to maybe get signs put out on people's lawns about and we got to remind people who's causing this problem in the private homes, the Ford government. So, and also started before with the Liberal government. So we need to remind the public because of all the deaths we've had in there. Because I feel that the seniors are a forgotten group in Ontario and Canada, and we gotta let them know we're still here.
Yep, I think you're right. Okay, Ann Clark.
I like the postcards that we could send out and put in our neighbors' mailboxes. We did that before and I
Yes.
thought that was very effective.
Mhm. Yes, no, it's true. Is there anybody else who would like to add? What else can we do? I'm not seeing any more hands here. What else can we do? What have we done in the past that has worked? Or what have we done in the past that you particularly liked? We have a couple of minutes here.
Last year, we put it in car windows as well. A sign that when you were, parked in a parking lot at the grocery store, people could see it and people could put those same wine signs in their windows.
Yep, that's true. Okay, Anne. Anne? You put your hand up again? No?
Yeah, I follow a lot
Rally.
of, I
The
follow a lot of,
rally always seem to get attention.
Okay. All right. Here's the other. Okay,
Yeah.
go ahead, Angie.
yeah. I follow a lot of doctors and epidemiologists on Twitter, and some of them have very, very, very large audiences. So if we could even get some of those leading figures on board, it would, because they have huge followings, they're reaching a lot of people. Lobbying them to put out some bullet points or whatever might be the most effective use of social media. I think that would be well worth it. So, because the other thing, it's going to be very hard to get to a lot of elderly people who are in long-term care homes. And I'll tell you this, because I study polling patterns and voting patterns, is a lot of people, if you've been voting for a particular party all your life, you're not likely to change when you're in your 70s or 80s, even if it's against their best interest. Why, like, you have to ask, why is the base of the Conservative Party elderly people? And elderly people are the ones who are the very highest consumers of healthcare services in our province.
Okay,
So why do
and
people
I've got
vote
one more
against them?
person here and we got 1 minute. Okay, Anne, if I don't mean to be interrupted.
No,
Carol.
that's
Stewart's hand.
Okay, Carol,
Oh, no,
do it.
didn't do it.
Hi, producing bullet point talking pieces so that people have a script
that's
when they
something
go
from
to a
No, but
public
I'm gonna get
rally.
rid of that.
or-
What I typed in.
Keep trying, Carol.
Hi, Stephen. Maybe you could turn yours off. Yeah, if we've got, we could share and press around
Okay.
point bulletins that you can use as talking points at election when they have coffee hour or they come at your door.
Remove.
Don't know if they're coming to
Where's
your door or
hand
not.
remove?
Okay, so I'm going to stop it there. So I just want to say to all of you, thank you so much. It's, challenging to do education by Zoom. So we survived this and I'm happy to say that. So I just want to say to all of you, thank you so much for all your participation. And I'm sure we'll see you all again. So take care all.